Abdullah will talk about the frontal cell variants and sinusitis.
Thank you very much, Mr. Chairperson, and all the gentlemen here. Thank you so much. I'm sorry I have to put up the slide again. You can see now. I stand in solidarity with my friend, but actually, the true honest story is that we've been told to put up this, these slides. But I stand in solidarity with my friends and to announce that this event is going to come after we have concluded this Congress. And you can see all the big names here. Some of them are already among us today. And also, besides that, I would like to also welcome anyone to join our society, ASEAN Rhinology Society. You don't have to do rhinology work to join. And you should also be happy to know that the membership is free, at least for a year. Okay, so please join us in this ASEAN Rhinology Society. So I guess my work is probably redundant. I'm going to repeat what my good friend Prof. Frontal mentioned just now. I didn't know that we're going to speak together. If not, probably I just put up one slide. But I don't want to disappoint the organizers, so please bear with me. And probably this is just my thoughts on this, the issues about frontal cells, sinusitis, and so as surgery. And this is what I put up here is what I've been mentioned in the literature. You read out on the frontal sinus surgery and whatnot. They mention about the difficult to understand, the anatomy is difficult to understand and whatnot. But I think basically and essentially it's not only about the anatomy, it's also because when we work in this area, we are working in the, where you have to use an angle instrument, an angle telescope. And I think that's a big problem. Maybe in expert hand, it's not so much of a big deal, but for me, and also those who are not familiar with this sort of, anatomy, working with angle instrument is no fun. It's going to be difficult. Usually, I find that the most useful, the most easiest to use is the 0-degree telescope. When you go, when you use an angle telescope, probably the 30 degrees is not so bad, but when you use more than that, then it's a bit more difficult to orientate yourself. I think probably that's the hurdles and also the challenges when you are working in this area. And in this area, you're working in a restricted space. The issue is always there's little margin, little room for error or mistakes because of all this, the significant or the vital structures surrounding this area. Okay, so if you want to understand this, probably the sort of relationship of the frontal sinus opening with, what Prof. Frontal mentioned just now, and what people is always scared of is his anterior femoral artery. Because if you are not careful, you tend to injure the anterior femoral artery. But I think what has been said is, is always is true. Is why I find that the anterior femoral artery is always one cell away from the frontal ostium or the frontal opening, frontal sinus opening or frontal recess to be exact. So it's always one cell away. And I've always found that whenever we open up along the skull base, you always find it over here. All right, but then again, there will always be a variation in terms of the locations and whatnot, and that is why Prof. Frontal mentioned about all those classifications that's been used, and we have used this for quite some time. I have nothing against this. I think it's one of the useful classifications that we can use when we want to understand about all these frontal recesses and whatnot. But the issue with this classification is that on the imaging, it's quite easy for you to see where the cells are, but when you do an surgery, it's going to be confusing. You know where the cells are because everything looks the same, and the orientation wise, you do not know where the cells are located, whether it's anterior and posterior. All right, I will explain all this because Prof. Frontal mentioned it just now. This is how it looks like. It's always being like they are using the aganazide as the focal points. So all those type of cells, whether 1 to 4, is always in relation with the aganazide. You can see that. All right. And again, I have nothing against it. It's just that when you are doing surgery, it's not that easy to understand where is the exact location of these cells. Okay, so if you go for surgery, this is how it looks like when mentioned about the techniques. So you preserve the bulla here, and when we go up there, you can see the opening of the frontal recess. And the advantage of preserving the bulla is that you don't have that sort of risk of injuring the internal artery, because internal artery is always above at the roof of the bulla cells. All right. You can see some of these, the aganesa cells and whatnot over here. And in certain cases, it may not be that easy for us to see, and we have to use the angle instruments, angle telescope especially. And ideally, it has been recommended to use the 45-degree telescope. But I don't have it in my hospital, so I always use 30 degrees, and if need be, I use 70 degrees telescope. And usually that's for the identification. When I do dissection, I change back to the 30 degrees telescope. Okay, so over here is that I just want to show to you that if you go to the frontal recess opening here, the internal artery is just one cell away from the opening of the frontal recess. So if you want to open up the agenesis cell, the frontal recess cell, if you have to be delicate in your dissection and whatnot, probably the risk to the internal artery is not that not that high. Okay. Okay. So again, if there are a lot of cells here, you can see the opening of the frontal recess is being pushed medially, and I think if you can understand this sort of orientation, this sort of relationship, then perhaps it won't be that difficult to understand all this sort of relationship of the frontal recess cells to the surrounding area here. And if these cells, this is the supra-bulla cells, it's gone up and there are like multiple cells there, then there are more cells than just the supra-bulla cell. There are supra-bulla frontal cells as well if it extends into the frontal sinus. Okay, so even though when you see on the CT scan, you can understand the relationship of all these cells in terms of the frontal drainage, but when you are working in this sort of restricted space, it's going to be quite challenging, and especially if we use the angle instruments. Again, if this is the right frontal recess, the same thing. If you find there are all these cells around this region, and you can see there's aganesa and supra aganesa cell there, it extends into the frontal recess here. And you can see that it's pushing the frontal recess openings medially. So the drainage, you can find that it's quite medial. In fact, if you are not careful, then you think that's the opening of the frontal recess, but in fact, actually, it's more medial to this cell. So I think probably that is what the message that I would like to convey to everybody here. If you are not careful, we are not sure about the relationship of and the orientation of the frontal recess cell, then you might leave the disease cells behind. All right. So then you're thinking that when we have done dissection around here, that you have removed all these cells, but in fact you have not done a proper dissection of the frontal recess. I think Professor Vijay Wamal and team has come up with this sort of classification, and there are people who are favorable about this classification, and there are also some people who are not favorable of this classification. But to me, it's always about using whatever tips and tricks that we can learn from this sort of classification to help us in improving our management of patient that has that needs for us to do a proper dissection around the frontal sinus. So Prof. Ruan had already mentioned what the cells are all about. The main thing is what I find from this classification is that it is surgeon friendly. So it's been structured in such a way that the cells are arranged at least the entry cells are being arranged with regard to the location of the aganesa, and the posterior base cells are arranged with regard to the position of the bulla cells. So we have the anterior cell, we have the posterior cell. With this sort of orientation, I believe it is more surgeon friendly. So when you go in, we can probably try to guess where and also see where the cells are located, because we know that these cells can be located anteriorly and can also be found posteriorly. I find that in that sort of perspective, it is probably easier to use as compared to the other classification. So I won't go into details about this classification, because I think probably Yuan Tran had already mentioned that and also explained to us all about these cells. So I would like to share with you a study that I've done in my center with my teams here. And we have used it in this IFAC to identify some of the cells in our patients. And you can see here, as we mentioned, the aganasa is the most common, right, in all population. And even other diseases have mentioned that aganasa can be found up to 90% over. But there are variations among the population compared to German population, Indian population, Vietnam population. And I think if Malaysian and Vietnam, we have almost the same sort of prevalence. There are high prevalence for the suprabular cells, right? There is the posterior base cells, but there are some variation in terms of the other cells, right? For example, in our population, we have a low prevalence for supraorbital epidermal cell, but you have a higher prevalence for that. And I find that in the Western population, they have a higher supraorbital epidermal cell. And I think we have to accept this. There are different prevalence of, this sort of cells in all the population. I don't think they are the same, except for the prevalence that we, at least in Malaysian and Vietnam population, we have the same sort of prevalence. High prevalence for the supraorbital cell. That means higher prevalence for the posterior base cells as compared to the anterior base cells. And in this study, they are studying to see whether the prevalence differs between race and sex. So the answer is yes. Between race and sex, there are differences in prevalence as well. And they probably also need to understand this. And they found that supraorbital epidermal cells are associated with the development of sinusitis. And in fact, the previous study that I mentioned, my team had done, we found that supraorbital epidermal cells, together with the frontal septal cell, which is the cell medial base cell, they also have a significant association with the development of frontal sinusitis. Reason being because supraorbital epidermal cells, they are located quite high up, where the drainage is being impeded or being restricted by this sort of, where the cells is located. And even with the frontal septal cell, where if the medial base cell, when they extended more medially or more laterally, that also will cause some obstruction to the drainage of the frontal sinus. And that's probably is the reason, our position, why these cells are responsible for the development of frontal sinusitis. And in fact, other studies also have mentioned similar sort of association. Okay, and the other advantage of having this classification is that it's easier to teach our residents because then we can say, okay, you have to find this cell. They are these sort of cells that are, you can find in the frontal recess. And also they found that this is probably applicable for them to understand and also practice in their patients. And also they understand that this sort of patient can be helpful for them to learn and also apply clinically. You can see the sort of response from residents is above 60%. I think probably that is quite acceptable. Okay, so with that, ladies and gentlemen, I would say that we have to be familiar. If we want to work in this sort of difficult territory, we must understand the sort of orientation of the cells around this area. And furthermore, especially because we are using angle telescope, angle instrument, it's not that easy to visualize in this area, especially when you have to use this angle instrument. So if you are not careful, we are not familiar with this sort of anatomy, then there's a real danger for us to cause some complication around this area. And also we have to understand this sort of different prevalence between the population as well as the race, as well as the gender. So in all the literature, even though there are some discrepancies between population, some literature mention about the role of supraorbital memory cell as well as frontal septal cell. As I mentioned, why is that so? Because of this sort of location where they are situated along the very restricted area of the frontal drainage, and that could be the cause why they are causing patients to have frontal sinusitis. But of course, this association needs further elaboration. With that, ladies and gentlemen, thank you for your kind attention.